This is the case of total anomalous pulmonary venous connection. This is apical 4-chamber view. This is right ventricle, right atrium. This is left ventricle, this is left atrium, and this portion is pulmonary venous confluence. That means all 4 pulmonary veins join together and make this pulmonary venous confluence. From there, one vein that either goes up or down. If it goes up and joins left innominate vein, also vena cava, that is the way how it drains. Otherwise it goes downwards and joins portal vein, and this is how it drains into portal vein, then portal vein to IVC, and then finally to right atrium. So ultimately that is the scenario usually we have to see in this case. But in this example, what we are getting, so this is pulmonary venous confluence, and one straight vein is coming out of there and joins so vena cava. That will I will show in other slides, next slides. Again, this next image is almost same thing. This is again the same thing, 4-chamber view. Probe is away from, that is towards the base, that is more caudal in orientation, and you are getting this coronary sinus. So see, this is coronary sinus. No significant flow in coronary sinus. It means the total anomalous pulmonary vein is not joining coronary sinus. Right atrium, right ventricle significantly enlarged. The severely enlarged, you say trivial TRZ is here. This is how the gradient across this obstruction. This case has got obstruction, where obstruction is located where a straight vein joins suave vena cava. So finally there is obstruction in pulmonary venous flow. All pulmonary veins join together make pulmonary venous confluence. From there one straight vein comes and that joins suave vena cava. At the joining, at the junction of straight vein and suave vena cava, there is flow obstruction. You can see the velocity, the continuous velocity, at the same time raised velocity. Like P gradient is 22 millimeter, velocity is 2.36 meter per second. You can see in this image 236 centimeter per second, that means 2 meter and 36 centimeter. Now you see this image, this is suprasternal image. You can see this is left innominate vein, this is right innominate vein, they join together, and this is superior vena cava. Try to understand, this is left side, so this is left innominate vein, this is right side, so this is right innominate vein, they are joining and making superior vena cava. You can see this is a straight vein that is coming out of pulmonary venous confluence. This is confluence, one straight vein is coming and joining, simply joining. This is superior vena cava. Here is the flow obstruction. You can see the turbulence. Good. You can easily appreciate the turbulence here, and that is the part where the pulmonary vein is obstructed. So ultimately what happens with pulmonary venous obstruction in case of TAPVC? So pulmonary venous flow obstruction means more pressure within pulmonary venous confluence, that will be more reflected in pulmonary capillary level, ultimately pulmonary edema, so shortness of breath. The child is only day 1 and having lots of shortness of breath. Day 1, that means just baby was born 1 day before this examination was done, and baby was symptomatic at that time of examination, echo examination. So that is what I want to highlight. If the pulmonary venous confluence giving a straight vein, and that is joining either left innominate or suave vena cava, in this scenario suave vena cava, otherwise it could join also the left innominate vein. That is more common scenario, but in this case is joining the suave vena cava. You can see the suave vena cava, this is left innominate, this is right, and finally suave vena cava. So here the flow obstruction. So flow obstruction is, venous flow obstruction means what? There will be more pressure in the pulmonary capillaries, ultimately there will be pulmonary edema, and that will represent shortness of breath, less oxygen saturation, proper oxygenation will not happen in that case. That is scenario in this case. Now the next image, again the same thing. This is suprasternal view. Obviously this is the coronal plane. So this is left side, left innominate. This is right side, right innominate. This is here. This is a straight vein is coming and finally joining. You see the opening here is very small. You can see here this portion, very small opening. You can easily appreciate here. This portion is very small here. The flow obstruction. The flow obstruction is presented as shortness of breath because of raised pulmonary capillary pressure, ultimately pulmonary edema, and babies having shortness of breath even on day 1. This is the, you can see the patient short axis view. This is main pulmonary artery, this is right and left pulmonary artery. You can easily appreciate in this image. This is arch of aorta. You can see the arch of aorta. Arch of aorta. Now see, this is very typical image. In this scenario, this is right pulmonary artery, this is left pulmonary artery, and this is patent ductus arteriosus. So in patent ductus arteriosus, here the flow is from pulmonary artery to aorta. That is flow from right to left. The scenario is what? So all collection is coming into right atrium. Right atrium is giving flow through ASD to left atrium, and right atrium is giving to right ventricle, then pulmonary artery, and pulmonary artery is giving blood to right and left male pulmonary artery branch at the same time through PDA to descending aorta. So this is the scenario. So more blood is going into descending aorta, less blood is going into pulmonary artery, then ultimately through capillary pulmonary vein, and pulmonary vein flows is obstructed. So in one way it is simply compensating to some extent because of large PDA. If the PDA is small, then baby will be more symptomatic in this case, because the more blood will go to pulmonary artery, so more blood will go to pulmonary vein, and if pulmonary venous flow obstruction, so ultimately lead to pulmonary edema and shortness of breath. So here the large PDA is in one way is saving the child to some extent. So the flow is from right to left, because right atrium is getting all sorts of blood, oxygenated and deoxygenated both blood, so only mixed blood, and mixed blood is going through PDA to descending aorta. So that is scenario in this case. So whenever you find 3 branches coming out of main pulmonary artery, the right one is right pulmonary artery, middle one is left pulmonary artery, and last one is, that is most lateral one, most left one, that is patent ductus arteriosus. That is the point to understand from this image. This is parasternal shock tissue view, this is aortic valve, this is right ventricular outlet region, this is pulmonary valve, this is main pulmonary artery, this is right pulmonary artery, this is left pulmonary artery, cursor left, this is PDA. That is the point to understand from this image. This is parasternal short axis view. This is most anterior part, this is most posterior part. Again the same thing. Again the same thing. Now you can see all the findings in one video clips. Now see, this is the obstructive flow. This is obstructive flow. You simply zoom the image, you can see obstructive flow. This is obstructive flow. Here the flow is obstruction. You can see the size. This is only a small size, almost 1 millimeter size of communication between straight vein and superior vena cava. This is superior vena cava. This portion is superior vena cava. This is left innominate, this is right innominate vein. This is superior vena cava. This is pulmonary venous confluence. This is a straight vein that is coming and joining the superior vena. The pulmonary venous confluence is very close to superior vena cava in this scenario, in this patient, and that is just connecting. But here the flow obstruction, that is causing a raised pressure within the pulmonary venous system, ultimately leading to pulmonary edema. But that is the point to understand. Whenever you will find the obstructed anomalous pulmonary venous connection, child will be having shortness of breath very early, even on day 1, day 2, day 3. So that is the scenario. Whenever child is very symptomatic and pulmonary venous connection, most likely scenario is pulmonary venous flow obstruction. That is the point. Again the same thing. One very important thing now is simply you see, you can see 3 branches. This is right pulmonary artery, R for right. This is right pulmonary artery, this is left pulmonary artery, and this is PDA. So whenever I find 3 branches coming out of main pulmonary artery, then the most lateral one, most left one, that is PDA. PDA, that is PDA. That is the point to remember. Here the right pulmonary artery, this is left pulmonary artery, this is PDA. All 3 is having flow from, you see, the same direction. So PDA has flow from pulmonary artery to aorta. That is the point. Obviously there must be more pressure within the pulmonary artery compared to aorta. That is why flow is from pulmonary artery to aorta, because all blood is going into pulmonary circulation. So ultimately pulmonary circulation will have more pressure compared to systemic pressure. So PDA is direction is from pulmonary artery to aorta, that is right to left. So that is the ultimate final things that I can show from you from this patient. The summary is this case is having total anomalous pulmonary venous connection and PDA, ASD, obstructed flow from pulmonary venous connection confluence to vena cava. This is the portion here. The straight vein is very short because pulmonary venous confluence and vena cava is very close to each other. So straight vein is very short, but there is obstructed. Simply revising, this is obstructed flow, this is obstructed flow, a spectral Doppler, 4 chamber view, coronary sinus level. So whenever you find left atrium is very small, see, the left atrium is very small. This portion is left atrium. So very small left atrium. This is PVC. So whenever you find very small left atrium, try to suspect TAPVC, total anomalous pulmonary venous connection. This is right ventricle, RV. This is right atrium. This is LV, left ventricle. So ultimately what you see, whenever you try to find out 4 chamber view, or try to find out how much is left atrium. So whenever you find left atrium very small in size and another chamber is very close to left atrium, that is pulmonary venous confluence, always indicates total anomalous pulmonary venous connection. That then you have to find out a straight vein, how it is joining, ultimately draining into right atrium. So you have to find out if it is going downward and joining the portal vein, then it is infracardiac. If it is joining coronary sinus, this is cardiac level. If it is joining vena cava or joining left innominate vein, or sometimes it joins simply straightly in right atrium directly. So because it's very close to right atrium also, sometimes it joins directly to right atrium. So then in that case, the vein that is communicating with right atrium and pulmonary venous confluence is very small, almost very small. Then we call it directly joining. If it's little bit, then we call it a straight vein. Usually a straight vein going up or down. Up in case of most common scenario is draining into left innominate vein. If it is down, it is draining into portal vein. That is common scenario.